Vascular access considerations in the COVID-19 patient population. Hi, I'm Matt Ostroff, and I am the Vascular Access Coordinator and Lead Clinician at St. Joseph's University Health. On behalf of myself and Sonosite, I would like to thank all of the heroes during this pandemic: the emergency medical service, the entire hospital staff from maintenance, nutrition services, cashiers, technicians, aides, physical and occupational therapists, managers, respiratory therapists, radiology, physicians, and of course the ones with the most patient contact day in and day out, the nurses. You are all today's soldiers in a war against a virus. You are all putting your lives on the line to save others, and we thank you. And we will never forget the service you all did for our global community during this pandemic. My disclosures are listed on this slide. Dr. Pitteruti said, and I quote, "The health emergency linked to the COVID-19 pandemic has led to a series of dramatic changes in the routine of our clinical practice, requiring the review of many decision-making processes. It has been my journey that prepared me for this crisis. I flew home from Germany on September 10th, 2001. Jumped on an ambulance on September 11th for my first day in New York City as an emergency medical technician. From the first day, being introduced to emergency medicine, I was witness to seeing fire, police, and EMS standing together, running into the storm. I saw the doctors and nurses volunteering to set up makeshift hospitals around Ground Zero. I saw the people of New York City bringing everyone water and food. American flags waved around our country, and we endured tragedy together. At Ground Zero, we all ran out of supplies. None of us had masks the first 24 hours. We carried empty equipment bags, improvised flushing the firefighters' eyes with nasal cannula tubing over the bridges of their nose. But nobody complained, and nobody went home. That was the first day I stood among heroes. After 6 years of paramedicine in New York City, I stepped directly into the emergency department at Mount Sinai Hospital, adding a new layer to my medic experience as a registered nurse. With patient ratios of 20-1, we ran around triaging and treating night after night, figuring out ways to multitask to get the job done, side by side with physicians, techs, and respiratory therapists. It was here that I discovered ultrasound and the role it would play in vascular access. I then went on to become a vascular access specialist and finally expanded my scope of practice as an adult geriatric acute care nurse practitioner. I stood on the shoulders of the vascular specialists that came before me, and they pushed me to learn and grow. Meeting Dr. Hickman and Dr. Broviak, hearing stories about Dr. Scribner and Tankoff, to attending the vascular conferences with today's pioneers, the ideas and techniques that I will share with you today are a collage of the gift of knowledge my colleagues have all shared with me. My objectives today are to define vascular access's role in the viral war hospitals are facing with the COVID-19 virus, to establish vascular access recommendations for access on stable and unstable patients, to describe the use of assistive tools in the morbidly obese, cachectic, and contracted patient, to examine options and alternatives when supplies are exhausted, and finally, to share experiences from a leading hospital in Rome, Italy. So hey everybody, just to let you know I'm recording this in real time. I just had to go and run and do 3 more central lines, one in the ER, one in the ICU, and then one more in an RRT. So here we are back, and we will continue on. Signs of COVID-19 goes viral. So we were running around placing lines everywhere when my partner Tony said to me that she was having trouble drawing blood from the patients. At the same time, I noticed the venous blood to be almost black. Patient after patient had the same finding, and I decided to post my findings to my vascular access group and found out that I was not the only one noticing this phenomenon. And within 4 days, it had reached 1.33 million people. We, now at our hospital, had a possible sign to determine COVID versus non-COVID. This also led us to examine hypercoagulability and to choose the best vascular access site based on the risk of DVT. We were finding non-compressible veins in the forearm, leading us to question whether peripheral access was the correct route. Communication, safety, and standardization. Globally, countries were all learning about how to care for these patients. Proper personal protective equipment, how to minimize contact and yet still provide optimal care. Every hospital experienced the same learning curve. Slowly, the drips were run from outside the room. Next came the ventilators being run from outside of the room. And then creative ways to communicate with staff from inside the room with Sharpie markers on the glass, walkie-talkies, baby monitors, and then labeling the rooms with the patient devices and the most vital information. But what about vascular access? The challenge seemed insurmountable with the incredible volume we were facing with patients. Our surgeons began placing lines due to the closure of the ORs, but where were we all going? What was our plan, and was there a standard of care? This is when I met with each department head and explained what I was seeing, what we could improve, how we could conserve on supplies, and how we could work as a team amongst all the chaos. No blind sticks for peripheral, arterial, or central access. The first and most important issue to discuss is the elimination of blind sticks. It is unacceptable in today's day and age to have complications with vascular access due to a lack of safety. Ultrasound has often been compared to a pulse oximeter. It is such a simple tool but mitigates such severe complications. Most physicians are surprised at the use of ultrasound to reveal the axillary vein in the deltopectoral groove. This eliminates the practice of blind sticking the subclavian vein. Pneumothorax is not an acceptable complication of vascular access when ultrasound is available. In addition, arterial puncture can be eliminated with direct visualization of the needle being guided to the vein. And finally, above and beyond all insertion methods is assessment. The Rapid Central Vein Assessment by Dr. Pitteruti and Tim Spencer. This method will quickly determine if your route to central venous access is patent. Practitioners talk about speed and the need to provide emergent access. The solution to this is simple. Place an intraosseous catheter in a severe emergency and establish central access in 30 seconds. Stabilize the patient and then perform a safe central line catheter insertion with ultrasound guidance. Quickly, the patient type was becoming more and more similar. Obese, male edematous patients. We also saw the different ranges of illness from mild to respiratory distress requiring intubation. In stable patients that are not intubated and remaining on a medical floor, ultrasound-guided deep peripheral access was found to be successful. The cephalic vein in the forearm is the first option, followed by assessment of the upper extremity for the basilic and brachial veins. In an emergency, the brachial vein is always with the brachial artery in the antecubital region. Dr. Pitteruti suggests the sterile placement of a midline catheter because this provides the ability to perform a sterile wire exchange for a PICC insertion should the patient require central access. Securement of these peripherals is paramount. Often, it is the patients on the medical floors that crash and are then either rapidly resuscitated at the bedside or transferred to the ICU. During transport, the IVs can become dislodged, and once access is lost, the medications cease to be administered, and these patients will pull out their endotracheal tubes. We had an incident where a patient was being transferred to the ICU after being intubated. Propofol was running, and the IV came out during transport. The patient awoke and became extremely, understandably combative, and due to his very large habitus, it took 5 people to keep him safe. I just happened to be in the hall when this happened and grabbed an ultrasound and placed a line directly into his AC, and we pushed propofol, which saved the man's life. He was so obese that we would never have established access, and while we were waiting for IM injections for sedation, he would have extubated himself. But the important ending was not that we successfully and safely got the patient stabilized. It was that I placed a central line and then removed the dirty emergent ultrasound-guided peripheral to prevent a peripheral line bloodstream infection. We just finished discussing the option of ultrasound-guided long peripheral access on the stable patient in respiratory distress. But for the unstable patient in respiratory distress, there is no question that the option of ultrasound-guided jugular or axillary vein insertion is not a safe option for the operator nor the safety of the patient. These patients cannot lie supine or even back at a 45-degree angle. Emergent access in our facility is obtained in conjunction with sedation for intubation prior to placing the patient in the prone position. The femoral vein is always large caliber and in the vast majority of the patients, patent. and is an excellent emergent means of achieving multi-lumen central access by eliminating 100% any risk of pneumothorax. This site is also far away from the airway, helping to distance the operator from the airway, as well as the nurse providing care and maintenance to the site. This site also conserves on resources as the femoral site does not require a confirmatory radiograph for tip placement. Traditionally, most physicians and practitioners access the femoral vein in the inguinal crease. With the majority of the patients being obese, this region resides in a skin fold, making the insertion site the least ideal due to inability to secure and dress the catheter, as well as subjecting the catheter to higher temperatures in a region that is covered. The common femoral vein can be accessed distal to the inguinal crease, allowing for a clean exit site and appropriate dressing placement and catheter securement. This site has been well examined and researched by practitioners performing mid-thigh femoral vein central catheters. This site outside of the crease is achieved using ultrasound to locate the vein in the femoral crease and trace it distally to the thigh. It will be a deeper puncture, but the femoral vein is a very large caliber vein, and this adjustment in insertion site is easily adopted into practice. I am proud to display two of our residents who have worked closely with me and adopted this method. Here they are with their first out-of-the-groin placement. For those uncomfortable with femoral access due to its taboo, it is easily replaceable when the patient is stabilized and intubated and sedated with a jugular or axillary vein insertion. In our experience, due to the hypercoagulability of the COVID patient, we do not place our temporary dialysis catheters in the femoral vein. Unfortunately, the progression of the unstable patient leads to acute renal failure. We have observed poorly functioning femoral dialysis catheters due to the patient's hypercoagulable state. We have not seen any issues with the jugular hemodialysis catheter insertion site so far at our institution. And to complete the trifecta of endotracheal intubation, central venous access, we have hemodynamic monitoring. Arterial monitoring and frequent arterial blood gases make early arterial catheter placement in the unstable COVID patient a key to early treatment, accurate monitoring, and medication titration. Remember that ABGs in most hospitals are drawn by the respiratory therapist, and establishing an arterial line allows the respiratory therapist to focus on other responsibilities. The adoption of ultrasound-guided peripheral vascular access is now commonplace in critical care areas such as the emergency department and the intensive care units. Arterial catheters can and should be placed the same way as an ultrasound-guided peripheral IV. Ultrasound-guided arterial access is safe and accomplished quickly. Assessment is key to this location, and this can be done by performing the Allen's test, examining the ulnar artery's ability to provide collateral circulation to the hand, should the radial artery thrombose, or the radial artery and ulnar artery can be assessed with the ultrasound as well as performing the Allen's test. Later in the presentation, I will discuss conserving resources during a crisis, but a sterile ultrasound-guided peripheral IV kit and a long ultrasound-guided 20-gauge peripheral IV catheter will provide you the same result as an expensive arterial line kit. For ultrasound-guided radial arterial access, you will always find the artery accompanied by a vein on either side. It is imperative to take into account the patient's palm when determining insertion placement to ensure that you have enough space to drop your angle as you walk up the artery. Following this crisis, the vascular access nurse's scope of practice should be considered to be expanded to include radial arterial access due to their high level of insertion success with ultrasound-guided peripheral IVs. Once the unstable patient has been stabilized, it is now safe to examine other central venous sites for triple lumen catheters, such as the axillary vein. The axillary vein is easily visible with ultrasound assessment of the deltal pectoral groove. It is in this region that the cephalic vein can be seen diving into the axillary vein, and the operator will find the axillary vein become more superficial as you pan up toward the clavicular bone. This site should only be attempted by experienced ultrasound users due to the risk of pneumothorax. The lung pleura is easily identifiable, and as long as you lead with the probe and not the needle, you will be able to avoid puncturing the pleura. Often, the vein sits right on top of this. In those cases, you should outweigh the risks and benefits of this site location and judge your skill with needle tip guidance. On cachectic patients, entering the vessel with a long peripheral IV can provide a safe entry to the vein and allow you to cannulate the vessel and then place your guide wire through the IV catheter rather than with just a needle accidentally popping out when you release pressure.